Good morning.
Good morning.
So this meeting is called to order. Notice of meeting statement by Commissioner Coher.
A meeting notice announcing the date, time, and place of August 15, 2024. Commission meeting was distributed on August the 13th, 2024 to the appropriate media and other groups or individuals who have requested notification. The announcement and agenda were posted at the Department of Disabilities and Special Needs Central Administrative Office on the website. The public has been notified that accommodations such as interpreters, mobility assistance, or other assistance will be provided to individuals with disabilities and special needs if requested in advance.
Welcome again. We need a motion to approve the agenda.
So moved.
Second.
All in favor? Aye. Ayes have it, so ordered. Invocation. Dear God, we ask a special blessing for those with disabilities, special needs. Keep them in your care. In Jesus' name, amen.
Amen.
Okay, and approval of the July 18, 2024 commission meeting. Need a motion to approve? Need a second?
So moved, Chairman. Second, Chairman.
All in favor?
Aye.
Ayes have it. Need the commissioner's update, starting with Barry. Commissioner Malfris.
Thank you, sir. I only have one update for today. And it is, I was reading an article in a wonderful magazine that I get called World Magazine, and in one of the articles it spoke about something called Unless You Scoops, which is a ice cream shop and school in Alabama that does a lot of technical and skills training for people with intellectual disabilities. And they've been going on for 10 years, and they have 2 campuses, and they have 150 students. It is technically an unaccredited school, but they do a lot of wonderful work for mostly adults with disabilities. And so if anybody wants any more information about this or another a very good accredited school which I've mentioned before years ago in Wisconsin, that is a truly accredited college for people with disabilities, please contact me on the website, and I will be happy to send you the information that I have about both of those things. They are wonderful organizations. That was my only update. Thanks.
Thank you. Commissioner Thomas.
I have no updates. Thank you.
Thank you. Commissioner Coher.
I have a book I want to recommend. It's called The Best Minds. It's by Jonathan Rosen. I have no financial incentive to do this. It's about friendship madness and the tragedy of good intentions. It's a great book. It gives you a lot of insight into sometimes when we make policies, we don't see the whole picture. And I'm learning a lot from it, so I'm just mentioning it so that other people can look at it if they want to. It's a long book. It's like 400 and some pages. And it's not easy reading because there's a lot of thought into it, but I'll be mentioning it more and more as we go on.
Very good. Appreciate that. Commissioner Woodhead.
I don't have any updates this time.
I don't have any updates to add either. Okay. Public input, we have none. On item number 9, Commission Committee business, Finance and Audit Committee meeting. Commissioner Woodhead.
Yep, we had our Finance and Audit Committee meeting this past Tuesday, and we went over the spending plan, budget versus actual, and I think, and then we also went over the contracts that will need Quincy to go over for 2025, as well as the 2025 spending plan summary.
That's tab 3, 4, and 5.
So under tab 3, you'll see the year-to-date performance for the proposed fiscal year 25 spending plan in the amount of approximately $379 million. And so through July 31st, the agency spent approximately $12.5 million in agency cash, which puts the agency under the budgeted expenditures by 5.04%. But again, this is proposed And that'll be a couple of agenda items down for us to go through the spending plan. All right, and that was for informational purposes. Then next, under tab 4, you'll see the contract renewals for fiscal year 25. They were included as part of the figures in the proposed spending plan. These contracts are broken down similar to the way we did it last year. I will note some of these amounts could change during the fiscal year for a couple of reasons. We're expecting a few multi-year contracts. They're slated to expire in fiscal year 25, and the agency is in the solicitation process. So I'm very confident that when we get those values, those, that were from 5 years ago to now, those contract values are going to increase. So it's the intent to bring those to the commission for approval if the annual increase exceeds executive limitations or unless otherwise directed. So if there's a particular question about any of the contracts on this list, then I can discuss those contracts. If not, then we can move for commission approval.
I just want to say I really like the report a lot with all of them listed, with the change from year to year. It looks great.
Yeah, it's meant to show you guys, hey, what we did last year, what expenditures came in, if there was a variance for any reason based on what we expected, and then we kind of use that to build our fiscal year 25 based on any anticipated increases or any new contracts. So you can see if it was a new contract, like if there's nothing in 24, then you see in 25 that there's an amount and it's a new contract. So it's meant to make it easier for you guys to kind of monitor these.
I would like to ditto that. You did a very good job with giving us context, which is what we need as commissioners a lot. I'm very thankful for this. Is the best one of these I've seen in a long, long time, maybe ever. But I only had one question about it, and I don't have any questions about the contracts, but there is a couple that I'd like to clarification on. But I'll get with you on that. If you don't mind another day.
Yeah, you guys will send me an email about any particular contract, and I can pull the contract and actually send you a copy of it and kind of break down the scope of work in each of these contracts and let you know kind of what it's for and, what authority we have to do it. So.
Well, I'll send you an email tomorrow and give you a meeting. Maybe we can get together for just about 15 minutes. But the only thing I was going to ask here is where it says 24 and 25 projected versus actual operating expenses for regional centers. That is all the regional centers together, correct?
Operating expenditures for regional centers, which page?
Page 12.
I'm sorry?
The page 12 of the.
Oh, you must be looking at the spending plan.
I think we're on tab 4, Barry, and the.
Yeah, that's the next tab.
Oh, sorry. We're on. I'm sorry. Go ahead. I'm sorry.
No, that's okay.
Go ahead. We'll look at that in.
Yeah, so this is just the 25 contract agreements.
I have no other questions about that.
And y'all want to vote on that?
Yes, I think we did need a motion to approve.
Commissioner Court?
I'm clueless on most of these contracts. I'm sure there's some due diligence on them. I pick one and I Google it to try to get some information, and I just don't know how much information I'm supposed to have as a commissioner to know about these contracts. When I look at some of them in $2.5 million, that's a significant amount of money to me. And I just wonder, we don't just renew them because they were there last year. There has to be somebody that's looking at these.
Yes.
Can you give me just a brief summary of how it's handled?
Yeah, so, and if I'm looking at maybe what contract you're talking about.
I just happened to pick one. I mean, I just looked at About Play LLC, and I'm not picking on you guys. I don't know who you are.
Yeah.
I looked it up on the website and it looks legitimate.
About Play LLC is an early intervention provider. And so when Medicaid is an entitlement program, correct? And so they bill who's Medicaid eligible. If the person chose them as their provider, they bill that provider. And this is part of, some of it's billed directly to Medicaid, depending on if it's like 0 to 3, and then we do the 3 to 6 population. So this is the 3 to 6 population. We're still considered the provider of record. We pay the Medicaid rate.
So it is fee for service.
It is, this is, yes, but we're still considered the provider of record. This is one of the services that we're still billing for, and they're not directly billing Medicaid. So they'll send us units. We pay the Medicaid rate for the population that's Medicaid, and we also have a non-Medicaid population we pay for that still meet DDSN's eligibility requirements. So this is both of those populations together.
So if somebody asked me about why are we paying somebody this much money, I'm not supposed to know.
Well, it's based on, the units they submit to us for billing, and, they have to document the
They have to
service.
justify
And,
it.
that they're doing this actual activity, and they're billing this many.
I would just say they're providing services on a fee-for-service basis, and it's paid accordingly.
Exactly.
Thank you.
So we'll go back, yes, we do need a motion to approve the contract listing.
So moved.
Got a second? All in favor?
Aye.
Commissioner Thomas?
Aye.
Ayes have it, so ordered.
All right, and then under tab 5, you'll see the agency's proposed spending plan for fiscal year 2025. The agency is projecting to receive approximately $342 million in recurring revenue from several funding sources. The largest two sources still being Medicaid revenue collections, as well as general fund appropriations. Expenditures are projected to exceed recurring revenue collections, meaning the agency is projected to spend approximately $36 million in our non-recurring cash carry forward. Most of those categories are similar to amounts in the last fiscal year. However, increases are mainly due to the 2.25% COLA and salaries, as well as an increased match requirement due to the ICF rate going up, or per diem, and as well as spending levels for renovations at the regional center facilities as recommended by the Legislative Audit Council. So those CPIP plans that we've approved in the past, it takes about 15 months for those to get going. And so we're seeing some of those start to come in. So that's why those spending levels are up, as far as this projection goes.
Once
So
again,
you just said we're gonna spend about $36 million. We're projected to spend next year about $36 million of our
Our non-recurring cash reserves.
cash reserves, okay.
And so, but we are projected to still, bring in $342 million in recurring revenue, mostly from appropriations from the General Assembly, as well as us billing Medicaid for those services like EI and self-directed services. So we're still getting, and the regional center per diem. So we're still getting that $342 million in revenue. And this is how we're kind of proposing to spend it.
if I were to justify Greenwood Genetics 15 million, what would I tell people?
So that's actually funded in the budget. It's a line that says Greenwood Genetics in our state budget. So that $15 million is kind of tabbed to them by the legislature. So we utilize it it kind of aligns with our mission in Title 44, where it says we do prevention services. So they do some prevention activities. So the contract does kind of line up with our mission, and that's why they've kind of put it there. So, and they are we're billing Medicaid on their behalf as well. So some of their claims are Medicaid eligible claims.
This is a legislative commitment, and we're just the
Yes.
intercessory.
We're a conduit for that section in our budget.
It's like a pass-through.
Yeah, some of it, excuse me, is pass-throughs, and then some of it's, like I said, we're the conduit to bill Medicaid on their behalf. So,
Oh, really? What percentage do we bill Medicaid on their behalf of that?
I think don't quote me on the numbers, but it's in the like $12 million range, $10 to $12 million range that we bill Medicaid for claims. And so some of this money is state general funds used for the match of that, and the other Medicaid comes in. So they're like a fee-for-service provider as well, but we're just billing on their behalf. And then sometimes there's non-recurring revenue that is in our section that we're used as a pass-through. So they do some outreach activities, they do metabolic testing. Those are the kind of things that route through, depending on if they're Medicaid eligible or not.
By the way, in the past, for the record, we've had a member of this commission for many years on that commission as a non-voting member. And so if anybody on the commission would like to be on that board, we've had a vacancy since Robin Blackwood left. Now, I don't know whether they fill that seat with somebody else or not, but if somebody's interested, they could contact, that's on the commission currently, could contact them and see if they could be a non-voting member if they wanted to be. Robin Blackwood was the last one that represented the commission on it, but she's been off for a couple of years. Well, a year and a half.
No, I think not. Do we have any other questions? I know we went-
Commissioner Thomas?
Yes, no questions.
All right, so we do need a motion to approve the 25 spending plan.
So moved.
Got it. So more, need a second?
Second.
All in favor?
Aye.
Aye.
Ayes have it. Supported. Old business. Commission recommendation for meeting frequency. Courtney.
Good morning.
Good morning.
At the June meeting, we presented research on meeting frequency in response to Legislative Audit Council recommendations and requested guidance from the commission on meeting frequency going forward. After some discussion, Chairman Miller asked that we reach out to each commissioner individually for feedback. I spoke with each of you and shared the results with Chairman Miller, and the results of that commission survey varied from quarterly to monthly meetings. Chairman Miller issued a memorandum proposing the commission meeting frequency for the full commission be bi-monthly or every other month instead of monthly. In the months the full commission does not meet, the Finance and Audit Committee, Policy Committee, and Legislative Committee may meet. All meetings would remain discretionary based on need, and this would allow staff ample time to prepare necessary documents from committee meetings to be presented during full commission meetings. The proposal also states that the new meeting schedule would begin in January of 2025. So I'll turn it back over to Chairman Miller for any discussion.
Floor is open to the commissioners. Do you want to discuss this today, or do you want to delay until we have a chance to decide which direction we want to go in?
I think we can always discuss it and then we can determine where we go if we want to make a decision today, but I think it'd be good to discuss now.
Go ahead.
I would like to recommend, not every month, but maybe 8 months, 9 months, taking, the December, January off. Some months maybe in the summer for those, on vacations and stuff, but, and of course that we would need meetings or, when we have approvals from either the policy committee or the finance committee, on the months that we weren't planning on meeting. And if we have months that we truly don't have anything to discuss, we could, take that under recommendation to not have a meeting. But that would just be my recommendation for the record.
The only thing I want to add to this is that the bylaws specifically cover this issue. And so the only thing we really need to decide, and it could be at the next meeting or the next, or whichever meeting we decide to do it on, is which meetings we are deciding not to meet at. Because if you look at section, I believe it's, I don't know where my notes are right this second, but I believe it's section 4, number 1 and 3 of the bylaws. They cover exactly when we can, that we have meetings and that the majority of the commission can call a meeting or the chairman can call a meeting. And it also says that we can have special meetings with only 2 people, with 2 commission members asking for it. So this is really already decided in the bylaws. The only thing we have to decide is which meetings we're not going to have this year, if we want to do that on a full, if we want to do that on if we want to already decide which months we don't want to have a meetings, AKA, I wouldn't have a problem with not December or January. But just say that, for example, if we decided that, then we would say now or next month, we're not going to have a meeting in December, January as of now. But that's all we need to decide, which months we're not going to have a meeting.
I think that would, right, because that'd be fair for everyone who has to prepare.
But it needs to be for this fiscal year, because every fiscal year, there are new bylaws. I mean, there should be new officers elected. And then that changes based on what those officers think and what the commission thinks at that time. So really, we're talking about the rest of this fiscal year.
Commissioner Thomas?
Yeah, I had to unmute myself so it didn't pick up background noise. I think a couple of months in summer. I'm not sure. Let's see, which month is it, Michelle, Commissioner Woodhead, that finance needs in summer?
Yeah, we would
Was
definitely.
it June?
No, definitely need to meet in August, for
August, okay.
like, we are this month, for the 25, or the next year's spending plan.
Chairman, just think in terms of maybe June, based on what she said, June, July. I mean, everybody's on summer vacation. That would make sense, I think. Then you get to Christmas vacation time, and allowing for people to be gone maybe December, January, or November, December. That gives you your Thanksgiving when staff. And I'm kind of thinking of staff here. It had rolled around in my mind as much criticism as we came under 2 years ago or so that we were meeting too much, and they were going after the policy committee for meeting, even though that's what we were told to do by the legislature is get all those policies reviewed. But if you meet too little, you'll be criticized for not being focused. The commission is like, the legislators might say, what are you all doing? You only met, 6 times last year. So you come under criticism if there's too little. So I would say to be able to meet maybe 8 times in a year might be rational, or reasonable. I don't mean rational, reasonable. So just throw that out. 2 months in the summer and 2 months close to Christmas would be my preference. Thank you, Mr. Chairman.
All right, thank you.
I live a scheduled life, so I'd like to have it scheduled to a certain date every month, whenever it's going to be, far enough ahead so that I can make a schedule. As you know, I'm late to many of these meetings. I have emergency patients or whatever, and it's very helpful for me to know when it's going to be way ahead of time. And I'm certainly an advocate for bi-monthly meetings.
Okay. I'm looking at, what I'm hearing is June, July, December, and January. So we're talking about 8 months of meeting. Is that the consensus of the commission?
The only problem I have with that is that June is the month for us to have election of officers. And so we need to meet in June for the election of officers. Now, July, January, December, January, or November, December, whichever one we decide here today, I'm thrilled about that. But June, we need to meet in order to elect officers. And I think that's a very important position.
August for finance and audit, but that's not the full commission.
So what, we still dealing with 8 and what we doing? July?
You could do July and August to cover
Well,
commission.
we'd need a full commission approval for the spending.
You could do that in September.
You can do it in September.
Yeah. So we're looking at July, August, December, and January. Commissioner Thomas, you okay with that?
Oh, sure. Yes, sir. Anything that everybody else is good with, I'm fine.
And if necessary, that there's an emergency, we know that we have to meet. So that would. All right.
Okay, so when are we going to elect officers?
June.
June, we're meeting in
We
June.
switched it around.
Say,
Consider
what 4 months did you just say?
July, August, December, January. Okay. All right, so I need a motion.
I so move, Chairman.
Second?
Second.
All in favor? Ayes have it.
Aye.
Okay. Quarterly incident reports. Ms. Ann Dawes.
I'm sorry, we didn't decide what day of the month. Is it still going to be the third Thursday? Is that,
Third Thursday is
Yeah.
always.
this is the second
So
Thursday?
we're,
right?
No, it's the
No, the
third.
third.
It's the third?
Always the third.
it's always the third Thursday.
Always the third.
Must be the first.
Okay.
Yeah,
This
it must-
started on.
It's just August comes
Must be a
early,
third
but
of
the
the
third
third or
Thursday in
something.
August comes early. But the only thing, so we are gonna have meetings other than that then?
Yes.
Okay, good.
All right. Ms. Dawes, how are you?
I'm doing well, thank you.
I'm doing much better now.
All right, so I have information for you for the quarterly incident management report. This can be found in tab 6 in your binders. As we wrap up fiscal year 24, the reporting rates for A&E were trending upwards. We actually had a 40% increase in the last quarter, which netted a 17% increase overall versus 2023. We have been tracking upwards throughout the year. That fourth quarter really put us over that mark. We are currently averaging 65 to 70 allegations per month. We have had now 14 substantiated allegations. Your report says 13. We had an arrest earlier this week that was reported. So we have 14 allegations for fiscal year 24 at this time. We have 133 verified non-criminal standard of care allegations, and most of those are related to dignity and respect issues or staffing and supervision issues, about 30% each. We have had 1,267 critical incidents in the community-based settings throughout the end of the year. We continue to have a decrease in the number of law enforcement calls, but we have had a sharp increase in the number of suicidal threats by our residential participants. And we're seeing a trend with many of the same residents making repeated threats as they are in need for increased mental health support. We had 112 deaths reported within our community-based residential settings. The charts and graphs are included there in tab 6. Please let me know if you have any questions about them.
Commissioners, any questions?
So this is actually like the year of the report. This is like our whole fiscal year. So
Yes,
this is
this
a
is-
whole year.
A year-end report for
Okay.
fiscal year 24. Of course, we're continuing with additional training opportunities. We continue to work with Inelectability to develop a curriculum that will be available for our provider agencies focused on abuse, neglect, and exploitation. We are working with the Ombudsman's Office and with SLED. They continue to be available to our provider agencies to provide additional training. The quality management team has had the opportunity to participate in provider level quality or risk management meetings and collaborate with providers on best practices. It's a great time for them to brainstorm about, what other agencies are doing.
Thank you.
Any questions?
Thank you.
Okay.
Good morning.
Good morning to you.
I'll be reporting out information for the quarterly incident management report for fiscal year 24 for the regional centers. This report was updated on August 14th. And so in 2024 compared to 2023, the regional centers increased individual A&E allegations by 23% from 171 A&E allegations in year of 23 to 222 A&E allegations in fiscal year 24. In fiscal year 24, there were 153 A&E incident reports, and as you know, one report may involve multiple allegations. In fiscal year 24, there were 2 criminal arrests, and they're still being investigated by the SLED agency, and 23 standard of care findings by the Ombudsman's Office. In fiscal year 24, critical incidents at the regional centers decreased by 3%. There were 171 critical incidents in 2023 and 169 in 2024. The death reporting for the regional centers in fiscal year 24 was 22 reported deaths, which have all been investigated by the SLED agency, and that's a standard investigation. That's all I have today. Any questions?
Commissioners?
Thank you.
So there's only one SLED, standard investigation going on right now, is that what you just said?
So for the criminal, for the A&Es, we have 2 arrests for fiscal year 2024, and it's currently in being investigation. Both of them are open investigations.
Other than just counting the incidents, do we look at them and try to find ways of preventing them next time, or how?
Yes, sir. So we actually, my team is responsible, risk management is responsible for going out and doing rapid risk reviews. And so what we do with that, we take our administrative review findings, and then we go out to the center to see what follow-ups was done, what training was done, and the regional center administrators, they're working with their team to reduce the A&Es by keeping them involved in training. And so we track the trends of what's going on from center to center. So the typologies, they vary from center to center. Like one center may have more physical abuse issues, and one may have like supervision issues. So they vary from center to center, but we track and trend, and we try to educate them on that as well.
So it's usually a training issue is what you're telling us then.
More so than less, yes, sir.
You're keeping a watchful eye.
We are.
Which eye you use?
Well, in my case, all 4. Thank you.
Thank you. Okay. Update on DDSN ongoing projects. Ms. Laurie, how are you?
I'm good. Good morning.
I love that smile, so we good.
So the first thing I want to talk to you guys about is waiver enrollment and the eligibility process. This is something that has been on the forefront of everybody's mind for a long time, because as you guys get those monthly reports, you realize our waiting list continues to grow and grow and grow for the home and community-based waivers. As a reminder, when we switched to fee-for-service in April of 2022, the match funding that went with waiver participants was transferred to the Department of Health and Human Services. So prior to April of 2022, DDSN did budget ask and did budget analysis to determine when additional slots could be added to the masses of people who are enrolled in the waiver. When that match was transferred to HHS, that responsibility became theirs, right? So at this point, we continue to operate the waivers, we continue to work through the waiting list, but DDSN as an agency doesn't have the authority to add additional people to the waiver enrollment logs. That has to be done by the Department of Health and Human Services. With that said, they are looking at the waiting list. They're actually doing a study right now of our waiting list. They have an outside contractor to determine kind of how many slots they might be able to put in their budget ask for next year. They have to look at a lot of things, because even if there was enough money to take everybody off the waiting list, there would be capacity issues in people being able to actually provide the services that are available through the waivers. So they're doing a lot of work around that.
Who was doing that again? Who was doing that again, the review?
So they have so Health and Human Services has a contractor. It's the public, I don't know the name of it. It's Empath. It's with the School of Public Health at USC. So they're the ones who are actually doing the study, and they're asking us for a lot of information. We're actively engaged and providing recommendations. So it's not like they're doing it without our input. So they'll be looking at, whether they can add additional slots. So our process improvements around waiver enrollment have been very focused on the management of the attrition slots through the current budget slots, right? So you kind of have this number that that there is money for people to get services. And as people enroll or disenroll, you can kind of fill those attrition slots, right? So we've done a good bit of work around slot allocation. We had a period in time where people were coming off the waiting list, and it was taking a really long time to get them actually enrolled in the waiver. So we put in place a lot of timelines and focus around preparing people for slot allocations. We're actually kind of pulling people earlier in the process, trying to do a lot of the work that has to be done to get them enrolled prior to their enrollment. We've added timelines as requirements for providers on those processes. We have staff here at central office who monitor those timelines. We kind of have these critical time pieces where we jump in and kind of push providers, you know, when stuff hits a bottleneck. We've added those timelines to the Alliant compliance review, so we're actually getting measurement on how providers are doing around those timelines. We are also working on cleaning up the waiting list because there was a period in time where a lot of work really wasn't done on the people who were way down. So we're doing annual contact with people that are on the list, and that allows us to be able to remove people who have died, moved out of state, no longer want the waiver. Sometimes people are enrolled in other waivers. So the good news is we've increased the number of removals from the waiting list that happen during the year, or like I track it monthly, right? So we've increased the number of people we remove, but we still haven't hit it, the number of people we're adding. So the waiver enrollment, the waiver waiting list continues to grow. As a reminder, in 2018, DDSN made the decision that every person who walks through the eligibility door is automatically added to waiting list, and that's a huge number of people, right? So even though we're doing what we can to try to pull people off, we're still just adding at such a rapid pace that the waiting list continue to grow. Any questions about that process and what we have going on with it? I will will let you guys know if there's going to be budget ask related to additional slots for Health and Human Services.
There will definitely be a budget ask.
Yeah, it just depends on how much, how many, right? The other thing that I wanted to report on was state level case management, was kind of what Dr. Fry called it. Back when she was here, we identified that we are having unprecedented, complex situations in case management and capacity issues in our provider in our provider areas. So we did a couple of things to try to help offset some of that. One of them is we have 4 case management specialist positions that work at this office. The work that they do surrounds constant follow-up and monitoring of provider activity, right? So they monitor the residential needs list to make sure that everybody who's on it, there are a lot of people on that, right, are receiving timely referrals and monitoring to get them into placement. They follow up on people on the waiver waiting list. So when we identify cases get closed and they're on the waiver waiting list, they try to figure out why they were closed. Do we need to remove them? That kind of thing. We have a report that we run monthly around expired plans for people that are waiver participants. That's a huge issue because authorizations are attached to plans. So if somebody's plan expires, it means we can't get them the service. So they follow up on expired plans to try to figure out what's going on. And then they do a lot of special projects. Like one of the special projects they're working on right now is DDSN has approximately 400 people who are judicially admitted to DDSN, have been over the years, right? So they have kind of gone in to try to make sure that we have a touch point so that we know what's going on with all 400 of those judicial admissions. We also have 8 complex care coordinators. Those are more akin to state level case managers. These folks are actually working cases. And we have targeted the cases that are the most complex where the agency is at risk. So those positions were not fully staffed until June of 2024. We brought some of them on earlier, but it's taken that long to get 8. The populations that they've targeted so far are people aging out of children's placements. So like kids in DSS custody who have disabilities who are going to need long-term residential. You know, when they turned 21, they're no longer in DSS custody. They have to move over. People who get dropped off at hospitals, and there are a lot of them, and have nowhere to go. Sometimes we know them before they got to the hospital. Sometimes we don't learn about them till they get there. People who are stuck in jails, people who are judicially admitted. We try to keep their caseloads to 15 people or less because we're asking them to do weekly updates into a shared spreadsheet that everybody has access to, including the executive team, the legal team, right? So that we all kind of know what's going on with these people. We have also, as part of that unit, established a lot of relationships with other agencies so that we can try to get ahead of some of this. We have weekly meetings with the largest hospital system in the state, as well as DSS, APS, and Child Protective Services. So we're just trying to we're trying to get out there and figure out who we have where. We're working on some data share agreements with DSS so that we can try to identify people. The problem is a lot of times we don't know these kids exist until it's a crisis, and then it becomes a mad scramble to try to figure it out.
What did you call those 8 people again?
Complex care coordinators.
Was that like the result of the survey to the providers that you sent out, or?
No, it was a result of the fact that so here's I said we have a capacity issue in case management, and we do. And one of the big capacity issues we saw was there are 2 types of case management. There's waiver case management, which is billed directly. It has a specific rate. There's another type of case management called Medicaid targeted case management or state funded case management. The rate of that case management is lower, right? So what we've seen is when a case becomes complex, we can't find providers to take the case. And there's a lot of reasons for it, right? Like when you have a case that's really complex, you can't use a newly hired case manager because you got to have somebody who can hit the ground running. The other thing is that even providers who were able to handle those cases, we were spending an enormous amount of time asking that provider to tell us what was going on. Hey, what's going on? What's going on? Because we're getting calls, we're getting bills from hospitals, right? So we're getting a lot of attention at this office. So again, these complex care coordinators, the concept is not that they provide case management for anybody on a long-term basis. They jump in, they do the case management until we can get people in a safe, appropriate location with supports. And when that happens, we push it out to the providers.
Commissioner Thomas?
I have another question about what you talked about before, which is when you talk about the waiting list and making the annual contact to people.
Mm-hmm.
How long have we been doing that?
2 years, 3 years, 3 years.
So before Michelle Fry was here, we were doing that?
We started at the beginning of the administrative contract. So that would have been 21.
Yeah, 2021.
21, 22, 20, yeah. We've perfected it a little bit though. So like the first time we did it, we sent out letters, right? There's thousands, tens of thousands of people. I don't know the number, so I don't want to throw a number out. So we started by sending a letter saying, you're on the list, this is your number, right? And then we just really didn't do anything more than that. So the second year we did it, we started adding a number for who to call if you have questions. And we started following up on any letters that come back return to sender, right? Because if they come back, that means the person didn't get the letter. Maybe they moved, and we have abilities to do searches to try to figure out if somebody moved out of state. Maybe they had passed away. Maybe we didn't have the right address. We need to send a letter to the new address, right? So that has required a ton of follow-up. I can't remember the number of return letters we got, but it's in the thousands, right? So it's not like we got 10. The other thing about return letters, I don't know if y'all have ever sent out a mass mailing, they don't all come back at the same time, right? So like you send out a letter in October and then you're still getting return letters sometimes up to March.
That's a good idea.
Thank you very much.
To work on the ones that returned.
Right. Yeah.
Don't leave yet.
Okay.
Under this heading, ongoing projects, you don't have a bulletin for ongoing policy changes, but could you update us on anything we should know about?
Sure. So we kind of had a pause on policy updates for a while when everything was being worked through 915, right? So we've kind of restarted this policy update. We have some policies that are in the hopper. We will start prioritizing the first policies that need to go through. Some of them will go through policy committee. Some of them we will work with the policy chairman to determine if they just need to come straight to the commission. For example, there's a couple of policies that need to be changed basically based on Medicaid updates. There's nothing really for us to decide. We just need to change our policy so that it's reflective of the Health and Human Services policy because it's for providers who are billing HHS directly. So you will see policies coming up shortly.
Thank you. Ms. Priest? Thank you very much.
Good morning.
Good morning.
Dropping some stuff. So there were questions about crisis stabilization and the ITAC. So I'm here to give you an update on those two topics. Crisis stabilization, or DDSN, actually standing up a crisis stabilization unit was an idea and a project that the agency committed to rather quickly. And as we did research and as we started trying to do that, the agency learned that it was probably not the best idea to pursue that. In order to have crisis stabilization at the time that we were trying to do it, state regulation did not allow DDSN to be licensed to have one. That has since changed. Additionally, to have a crisis stabilization unit, the agency would have needed a full-time psychiatrist. We did advertise for one and we were not able to hire one. So the units that were intended to be used for, or a unit that was intended to be used as a crisis stabilization unit has been in use for over a year as institutional respite, which is a Medicaid reimbursable service. And it has, for the most part, stayed full. We have staff that are overseeing it that are doing an excellent job with some difficult people and with a lot of movement in the people that are there. The question around, one of the questions that was asked around crisis stabilization is who's kind of taking the lead on that. So just as a reminder, in the spring of 2023, the Department of Health and Human Services, the Medicaid agency, released a grant for hospitals to come forward to address the state's need for behavioral health crisis stabilization services. In June of 2023, $45.5 million in grant funds were awarded by the Department of Health and Human Services to hospitals in the state, specifically for crisis stabilization. In January of 2024, Medicaid amended or released a bulletin indicating that coverage for hospital-based crisis stabilization would be covered by Medicaid. So Medicaid members, if you need crisis stabilization in a hospital-based setting, that is now a covered benefit for the Medicaid member. So one of the questions asked was, kind of who is in charge of crisis stabilization, and it seems that the hospitals and Medicaid are taking the charge on crisis stabilization, which in my mind makes sense because crisis stabilization is not something that is unique to people with intellectual disabilities or DDSN eligible people. There are a lot of people who get in crisis situations, and the state's response to that probably should be more broad, or I agree, needs to be more broad. DDSN doesn't specifically track the number of people that we deem in need of crisis stabilization. Lori talked about her staff, specifically Melissa Ritter and her team. They have done an excellent job of having conversations with hospitals. A lot of folks that are coming to us have been dropped off in hospitals. They are often dropped off in hospitals because of their behavioral health needs, not because of their acute medical needs. But Melissa and her team have done a great job of working with the hospitals to make sure that the hospitals understand what DDSN can do and can't do. There are things that a psychiatrist in a hospital can do that a staff at a regional center or a staff in a CTH2 cannot do. So we make sure that those are understood so that when people are coming to us, hopefully they are coming to us once they are stable. I think there is some disagreement between DDSN and the hospitals on what stable might actually mean, but we're working on that. And Melissa and her team, again, I cannot say enough good things about what they have done to support people with disabilities throughout the state and those coming to us. Most of the time when the people are in the hospitals and needing to come out, sometimes they have never been known to DDSN, so they may have lived in the state their entire lives. DDSN's never heard of them. We've never determined if they're really eligible or not, so that's one hurdle that they will work with those hospitals through. The other thing is usually those that are dropped off at hospitals are not going back to their home, wherever they came from. So they need a home, which means they are in need of residential services, and that's a difficult thing to do as well. Again, once those crises, they are as stable as they can be. As far as other avenues, Julie Cook, who is on my team, has had some conversations with one of our current contractors about the possibility of utilizing some beds that are available or potentially available in a setting where there is a psychiatrist on staff who can treat and help treat to stabilization. So that's kind of the crisis stabilization. Are there any questions?
That's very thorough.
Thank you.
So we really don't know how many, that was quite thorough based on the questions, thank you, but, so you really couldn't give even a round number as to how many people we deal with in the hospitals that they deal with that are duly diagnosed, meaning diagnosed with developmental disabilities and, mental disabilities. So about how many people do we deal with that have duly diagnosed with both?
So in terms of the number of people who have an intellectual disability, a traumatic brain injury, so DDSN eligible, plus having a diagnosed mental illness.
Yes.
That is huge, a huge number. And we don't necessarily track that. So we don't have a good way. In fact, The last time we tried to figure it out, it was literally going through the residential needs list, people who are in critical circumstances and in need of residential, and looking person by person into case management data to see if there was a diagnosed mental illness. So it is a hand.
So you'd have to go through every individual case to find out.
Correct.
Okay.
Correct. At this point, that's what we would have to do. It is, my guess is majority of people. The second topic is the Interdisciplinary Technical Advisory Committee, also known as the ITAC. In August of 22, well, actually the summer of 2022, we were encountering a lot of people coming out of hospitals, people in those crisis situations where we were finding it difficult to know which way to go with them. The thought at the time was that we could pull together an interdisciplinary team of professionals called the ITAC. We could present information about people or cases. I don't like to call people cases, but information about people or case information about people to the ITAC, and then perhaps those professionals could provide the agency and the agencies that were specifically supporting the person, the case manager, whomever, some recommendations that would go beyond what the case manager knew or something different. So we had about 4 professionals on that. We had a board certified behavior analyst at the doctoral level. It's a certification, specific certification, BCBA-D is what it's called. We had a policy/case management expert. We had an internal medicine physician, and we had a psychiatrist. Okay. So, and then there was a team lead. So the team lead and the physician were employees of DDSN. For a while, I was a team lead. For me, it was an other duty as assigned. The physician is a physician who works at Midland Center. For him, it was an other duty as assigned. There is one, the psychiatrist, DDSN already contracts for her time. It was added to that contract, leaving the 2 other contractors, the policy expert and the BCBAD, as just direct contractors for the purpose of the ITAC. Okay? I've said all of that to say the 2 contracted employees billed DDSN when they delivered services. So when they reviewed a record and when they participated in a meeting, and when they didn't, there was no pay. Before we started the ITAC, we were very specific about the criteria that would be used for an appropriate referral to the ITAC. We got a lot of inappropriate referrals to the ITAC, but at the end of the day, there were about 30 people whose information was reviewed by the ITAC. The ITAC met fairly consistently between August of 22 and October of 23. In that time, we saw about 30 people. The other use of the ITAC was that if we had questionable care decisions about people and we needed a third party's input, we had the ITAC to go through to say, look at this and tell us if this person is appropriately supported in this kind of setting. We also sometimes have decisions regarding DDSN eligibility that are close, right? So they're close. They could go either way. Those decisions, we have sent those information about those people, we have sent to the ITAC along with the criteria for DDSN eligibility and asked for their opinion as to whether or not the person should be eligible. It's a recommendation to the agency, but it's been very valuable to have those experts all look at it and say, I think it's this or I think it's that. So they've been used in that way. As far as the ITAC is in terms of how it was initially envisioned, I do not think that we've realized the efficacy from it that we had hoped we would. Part of that is that if you have a recommendation for a service, it's very hard to get that recommendation actioned in the real world. For example, it looks like somebody needs psychotropic medication. They need a psychiatrist to prescribe that medication. The person has Medicaid. They cannot find a psychiatrist in the middle of nowhere in the state of South Carolina who accepts Medicaid and will see them. So there were rubs like that. It could be that the board certified behavior analyst would say he needs a behavior support plan that looks more like this. But then there was not a behavior support provider who could go in and write a behavior support plan that looked like that. So their expertise was spot on, but the ability in the state to actually execute those recommendations was not easy and often not possible. So in terms of efficacy, we have not continued it since October of 2023. All of the contracts are still in place, except for the board certified behavior analyst who in July declined to renew his contract. He decided to retire, and we have not sought to fill that. So in my personal opinion, the ITAC can exist, but is not functioning. So that is the status as we see it now.
Kind of provided like, not a case,
Is it on
not a
hold,
case
or-
study, but kind of provided information that we could gather that we couldn't provide services for. So you have an outline of all those.
Well, yeah, we know very well what that is. I think the other thing to say about that is that some of the people that would have been presented to the ITAC are those same people that are now
The hospital.
that Melissa Ritter's team is very successfully being able to action recommendations and plans for.
So
Because that piece did not exist when the ITAC was fully meeting. But again,
So it's kind of good to know that just because we maybe not done anything since October, they're really kind of getting picked up in a different initiative.
they're not coming through as ITAC referrals.
Right.
The possibility to make a referral to ITAC is still there. We've not taken it down. The last, I would say, 5 referrals that did come through were not appropriate referrals and would not have gone to the ITAC anyway. Having the expertise for getting an unbiased opinion on eligibility decisions and care decisions, I think is invaluable.
On the ones that are kind of.
So basically, it's on hold and we just haven't reenacted it, and we could at some point reenact it, is what you're saying, or we will not reenact it? It's been canceled.
Well, I guess that, it is standing. It is not active. We are not paying money.
We did that on a contract basis anyway, so we just been based on how much
Yeah.
work.
Correct.
Which is
Which
still.
is
So we
probably-
can
which is
keep
probably
a
good.
contract in place, and should a case come up that desperately needed to go to the ITAC, it could do it. I don't know that there's a lot of value at this juncture in searching for a board certified behavior analyst to have a contract. But again, but certainly, I think there is a lot of value in maintaining the contractual relationship with those professionals to be able for DDSN to have a third party weigh in.
Yeah, I was gonna say, would it help then to continue that, just so we can have those people review, you know, the ones that are on the edge, you know, as far as their eligibility goes? And so you don't use that for that right now? What do you?
Yeah, so we've used not the whole committee, but
Yeah.
because we have the contracts, like, it seems like a lot of our very close calls are autism. And we have someone on the committee who has a long history of service provision in autism or actually two people. So we use them if we have something that we feel like we need another set of eyes for.
So with an
Right.
eligibility decision, we would pull in the members of the ITAC with that particular
Right.
expertise for them to look at it. On the care side, we would pull in the internal medicine physician, maybe a psychiatrist to look at it.
Yeah.
So kind of going both
It's
ways,
just not a full committee, right?
right? So the board certified behavioral analyst might not can give you much information on
A diagnosis.
a diagnosis.
Right.
Or care, like whether it's skilled nursing or acute care, hospital level care that the person really needs.
Very good.
The only thing I was gonna ask you said there was 30 cases, and by the way, you're doing a good job with presenting, maybe you should present more often. There were 30 cases that they had heard. How many cases do you think were referred to them that was not appropriate? Or was that part of those 30?
Oh, no, 30 was what they heard or what they reviewed. So they reviewed 30 cases. There were probably at least that many inappropriate referrals.
Okay, thank you.
Very good.
Thank
Appreciate you.
Thank you so much.
Next item on the agenda, new business, property conveyance, central office, Director Holloway.
So as everyone is aware, central office will be relocated sometime within the next year to Oteri Park. As a result, the Department of Administration has made a request to DDSN and the agencies that will be relocated, that we surplus our property that we're currently in. By surplusing the property, it gives the Department of Administration the authority to sell the property. And they're seeking to do so, and they're requesting that they be able to place it on the next agenda, SPA agenda, which will take place, the next meeting is scheduled for August 27, 2024. The reason for the properties being surplus is that we're no longer needed because we won't be here. We'll be in the new location, which many of you will get to preview after this meeting. Any questions in regards to that request from the Department of Admin?
No, I don't have any. I'll make a motion that we surplus this building since we are moving to another one. And you're thinking it's gonna be sometime before June of next year?
Well,
I mean, of this year?
of next year,
I mean, of next year.
2025, the move, you mean?
Yeah,
So,
so that we'd be vacant, I'm saying.
yes.
This
So
building
the
vacant.
plan is what we've been told, and we're gonna have a regular cadence of meetings, every month. But the last meeting we had was, I believe, in July. And the plan is to have every agency out of their current buildings no later than June 30th of next year. And they're gonna stagger us, the move, of course. So my understanding that DPH would move first. And then the three remaining agencies, they haven't decided which order we're gonna move in. DPH is moving first because they have two buildings that they're currently occupying, and they have more employees to move. But we all have to be out of our buildings by June 30th of next year.
DPH is
Department of Public Health.
Public Health.
So restate your motion, please.
Oh, I make a motion that we, surplus this building,
Which will allow
which
for it
will
to
allow
be.
for it to be sold by the Department of Administration.
Can I get a second?
Second.
All in favor?
Aye.
Ayes have it, so ordered. I'm glad we did that because the Navy just arrived.
Thank you. I'm sorry that I could not get that word out for a while
The
there.
neighbor's all
Navy, no,
this property, this is property.
Navy.
Rob.
Oh, the naval man. Just, now I got it. Hey, man, you really have to think about what you're saying. I don't even have to think about it.
Okay, director's update.
All right, so I think we're still in morning. Good morning, everyone. I'm gonna take a few minutes to provide some updates and important announcements. So I wanted to remind everyone in regards to Training Tuesday, DDSN is offering case management training opportunities from 10 a.m. until 12 p.m. on the second Tuesday of every month. The September training topic will be case management and waiver assessment. Management providers and staff are training sessions. At our regional centers, the DDSN regional centers, the Parents and Guardians Association of the Coastal Center is hosting its 13th annual golf tournament fundraiser on September 14th of this year. All proceeds will benefit the residents of the Coastal Center. Please check all of DDSN's social media channels for more information regarding that golf tournament. Midland Center honored their psychology and social work interns for their work with their consumers this summer with their celebration luncheon, and wish all of those students well wishes when they return to their respective colleges this fall. In our autism program, autism is always busy. Share resources at ETV's virtual back to school professional development training, and also did crisis intervention trainings for law enforcement at Spartanburg, City of Columbia, and Richland County Sheriff's Office. In outreach and education, we attended the South Carolina State Museum Accessibility Morning as an exhibitor. We participated in back to school events with the Department of Education, SCETV, First Choice Community Center, Shaw Air Force Base, Charles Drew Wellness Center, and the Richland One Education. We also served as a committee member in planning the 2025 Children's Trust April Awareness Program. In regards to transition and employment updates, by August the 1st deadline, DDSN providers will have successfully transitioned 100% of consumers earning sub-minimum wages to vocational service paying at or above minimum wage and other services. No regional center or qualified providers will pay less than the minimum wage to any individual being supported in that service. As a reminder, we're still taking nominations for the Palmetto Award. That deadline for submissions is September 16th of this year. Just for those who are not familiar with what that is, it's a recognized county government that provide outstanding support to citizens with disabilities. So if you believe your county deserves that award, please nominate them. I want to end with my employee spotlight, which is my favorite part of my director's update. This month, I'd like to spotlight Teresa Grant, who has worked at the Whitney Center for 25 years. Teresa started around 1988 while in high school and worked each summer at the Whitney Center. When she graduated from high school, she returned because she enjoyed helping consumers. Teresa has worked as a DSP-3, HSS-2, and an interim FOD. Her favorite memory at Whitney Center was going to the Special Olympics for the very first time and winning a gold medal with her unified partner. Teresa said it was very exciting. I didn't even know what I was doing and we won. When asked what motivates her to work at the Whitney Center, Teresa responded, I enjoy caring for the consumers at Whitney. This is my second home. These are my babies. I love what I do. My family already understands if there anything that arises or my assistance is needed, I must ensure my babies are okay. We want to just spotlight Teresa and all her hard work and continued dedication to DDSN, specifically at Whitney Center. So that concludes my updates.
Well, our hats off on behalf of the commissioners to Mrs. Grant. If I get a hello on that.
Hello.
Okay. Next scheduled meeting is September 19th, 2024 at 10 a.m. And Vice Chairman Woodhead will chair the meeting. I will not be in town, but I will be up on Zoom.
Only other thing I wanted to bring up, I didn't mean to bring something else up we've already decided, but we might want to revisit one thing that we talked about the meeting frequency, because the next meeting, because November, the third Thursday, comes close to Thanksgiving. And so I don't know if we might want to consider November instead of January, but I just want to talk about that another day.
Okay, sounds good.
Thank you.
All right, I need a motion. Any other? Yeah.
Motion.
Next.
All in favor?
Motion to adjourn. Favor.
Aye, have it. So ordered. Thank you very, very much.
Are you trying to